Okay, so I have no disclosures, except I'm not an expert in cost effectiveness. So you're not going to get bored with a bunch of slides looking at quality of life analysis. This is the only slide of that I'm really going to show. And it's not in shock. It's Impella versus balloon pump for high-risk PCI, which was the PROTECT 2 trial. And actually, it was interesting. It showed that Impella had better quality of life, better cost effectiveness than balloon pump, primarily because you could get patients out of the intensive care unit sooner. So there was some advantage. When you looked at Impella use in terms of cost effectiveness with other medical treatments, it looked pretty darn good, actually, again, in a non-shock setting. LVADs, of course, are not going to be cost effective. Now, it's hard to talk about cost effectiveness when we don't know what device is effective. So I think that's an important concept as we sort of go through these slides. It's also important to realize there is a transition. It hasn't happened yet, where we're moving away from fee-to-service towards a value-based reimbursement. And obviously, that's going to change the calculus as we figure out how the bundled payments and the shifting of risk from CMS to providers changes our evaluation of cost and cost effectiveness. It's important to realize, as we're going to hear about in the next talk, that a lot of shock is treated in community hospitals, often at centers half of the time that are doing less than 500 PCIs per year. So it's not always at a university center. I think the tragedy in America right now, there are many rural hospitals that are going to close because economically they simply cannot keep their head above water. And as we think about cardiogenic shock and the treatment of that, we're going to have to really sort through what those economics are. So what are the issues? Will, in fact, widespread use of ECMO and Impella increase? Will the new SCAI shock classification have an economic impact? Will the spoke and hub model, what's that mean to my hospital finances? Again, there's zero research right now on cost effectiveness in shock. Reimbursement for MCS could change immediately, and I think it's important, as Bill O'Neill has said for over 20 years, that the most bang for buck with cost effectiveness and mechanical support in shock is for younger patients with little comorbidity. The original shock trial that showed no benefit in patients over 75 years old. David Cohn is the expert in our field on this. He was kind enough to lend some slides to me, pointed out the cost effectiveness is not the same as cost saving. Treatments that increase costs may be cost effective if the benefit is worth it. These are some sort of common treatments, and you can imagine that MCS devices are not going to come in as cost effective as CABG is. But that's not the point. The point of cost-effective analysis is not about saving money. The point is it's a technique to optimize outcomes in the face of limited resources. We all know that balloon pumps are used less, ECMO and Impella use more, but still balloon pumps are used way more often than ECMO and Impella is. In fact, when you look at it, not every hospital in America has ECMO and has Impella. And those sites that have only intra-aortic balloon pumps are taking care of many shock patients. And when you talk with them, they'll tell you, we use this because it saves cost. Bill was going to show this slide, but there is some variation in Impella outcomes. The top 20% of sites have a mean survival of 76%. The bottom 20 of mean survival of only 30%. So we need to get better with the use of Impella, and you can't do cost-effective analysis until you've used the device in absolutely the best way that you can. Spoke and hub, we're going to hear about next. I think basically the issues are, do you take care of that shock patient in the outside spoke, or do you come into the hub quickly, and what's the effect on cost? What never gets spoken about, except by your patient, when they complain to you about the cost of the helicopter ride, is what is the cost of aero medical transport? Now, it was a delightful year as president of SCAI. There was good, bad, and ugly. The good is David and his co-authors published this. Fantastic work, very, very happy. The bad was when my partners saw that, they said, geez, there's nothing about timing. And I think it is important to recognize all these devices, as Bill was pointing out, are time sensitive. You've got to get the device in sooner rather than later. No matter what you use, won't be effective. Cost-effective analysis isn't going to work if it's too late to save a life. And then the ugly is that during my watch, CMS basically cut the reimbursement for ECMO without asking anybody in this room. And along with ELSO, ACC, HFSA, we were able to get them to change that. But it really, I think, opened my eyes up, and it should open your eyes up, that reimbursement for Impella and for ECMO really could change, and we need to keep our eyes on it and make sure we have some insight and input into that process. We're going to get better, no doubt about it. Results everywhere are getting better in terms of our survivability in our treatment with mechanical devices, ECMO 43%. But again, a cost side is the complications that occur with these devices. We talked about this. Ali left, but he mentioned yesterday it's only 10% of the time that you need an Impella or an intra-aortic balloon pump. Other folks said, no, it's 40 to 50% of the time that I put an ECMO in, I need an Impella or balloon pump. The effect on cost is significant, and the timing of whether or not you're going to put in Impella or balloon pump with ECMO is significant. So what MCS device works and in who? Once we get that answer, we can figure out the cost effectiveness question. Thank you for your time and attention.
Questions?
Just a comment. I thought that was great. Don't you think it would be valuable for us to attempt to define some of these, what we think are cost-effectiveness variables? The point is, otherwise you wind up in the situation where you have to send a response letter to CMS telling them, no, you're making a mistake. And I think that's where, physicians typically are not involved in that process. And I think more and more we have to gain that element within our ranks, both in terms of economics, legal, and other aspects, to be able to get those things out ahead of the curve rather than be behind and always lag. Because otherwise this is going to continue to happen. And as we were just chatting over here, a cardiogenic shock is not cost effective no matter how you cut and slice it in the general description of the term. But it is clearly effective and it's life-saving. We need to come up with a way to get that understood, because otherwise regulators are going to come in, because we have this quadrangle way of how money flows in healthcare. It's not a simple contract, one-on-one.
No, I think that's right. We have cost-effective data now for TAVR and for MitraClip, and so you're exactly right. I think the other side of the argument is everybody in this room wants to save a life, and frankly, they don't care about the cost. I don't care about the cost when I have a life in my hands. On the other hand, if they're 87 years old with a creatinine of 3, with COPD, is that the patient to escalate on?
I mean, the ethics issues are a little separate. We didn't mention that word yet here. I think ethics is a whole other situation. It affects it, but I think some of these sort of economic variables and what we think are important economic variables, we need to get those in front of people rather than being told, this is not like some simple Baxter, Harvard Business School strategy of how you manage healthcare.
Great point.
So, David, I think that was a great summary. I want to say that value-based care is spoken a lot, and I think physicians know what that means in their patients. And I think administrators are getting to understand that from the point of view of easily you could just say, well, our registries have 30-day outcomes, and value-based care is who survives more at 30 days. I think that's weak. I believe in survival. First thing you got to do is survive, of course. But if you ask a patient who you take care of years later, who had a huge infarct, that's been out of the hospital for 10 years, that's value-based care. And I think the question I was going to ask this question, but we're not out of time with Dr. O'Neill. The registries that are coming up like his, there's a Cardiogenic Shock Working Group registry with Naveen. I know he works very closely with him. These registries, which by the way, that's the one that defined that across the SCAI stages, you're halving the mortality if you use a PA catheter. Now that's value-based care for the PA catheter. I want to know if you guys are looking at the leadership level to define what is a one-year outcome that is reasonable for someone who gets all the perks, door to unload, so early unloading, early reperfusion, and on top of that, you know, the antibody that I talked about in my first talk. It's expensive,
Right.
but what's value-based care?
Yeah, I think those are great points. As far as I know, that's not being looked at right now because we're trying to prove the science. But I think, as Marvin said, at a leadership level and a society level, we definitely want to keep our eye on that ball. Excellent points.
I think that the other thing too is, can you imagine a world where the pump that everybody thinks is perhaps the most potent, suppose the Impella costs the exact same $500 as a balloon pump. It still has more downsides in terms of risks. So really a net clinical benefit. So forgetting cost at all, because the reason why most cath labs don't have Impella is because they don't want to buy the consoles. They live in fear that somebody by mistake will drop a $30,000 catheter on the floor and be unable to use it. But if the cost is zero, it's still a bigger device. It's still more ways to muck it up. We still don't have a device for dummies that anybody could just put in, whereas most of us, even a resident, could put a balloon pump in with somebody
Right,
standing
so
next to them.
They'll shortly have a 9 French device, shortly meaning the couple years. And so I think, frankly, Jim Burke's going to talk a little bit later. Our experience in Allentown was that it was pretty equivalent to a balloon pump in terms of complications, clearly just as easy to put in. So we didn't have that experience of groins and all that stuff. Again, I think you just got to you have to use it right, like any device.
David, I really do want to correct a misimpression here that is being populated since that Amin article was published. Those are bullshit administrative databases, and there's no way that you can compare one therapy versus another. All right, the only way to compare it, the gold standard, is a prospective randomized clinical trial. There's one in the field, it's called PROTECT 2. We randomized balloon pump versus Impella. There was no difference in bleeding, there was no difference in vascular surgical repair, and there was a hell of a lot, no difference in stroke. So the adverse events, so this perception that Impella is more dangerous than balloon pump is wrong. But if you have somebody that doesn't know how to stick the common femoral artery and doesn't know how to close them, you're going to have problems. There's no question. It's a mechanical device. What we have to do as a field is teach our operators to use all of these devices. If you're going to use them safely, and you'll get better results. But again, I really want to tell you that those administrative articles have really enormously harmed the field because the perception in the community is this device is more dangerous. It's not, if it's done in the right hands.
But in a randomized trial, how do you factor, your point is very well taken, that the operator's skill matters. But the first victim of any randomized controlled trial is operator skill. Because you couldn't tell me today that Dr. Cooley operating on a post-MI VSD had the same outcome as a fellow who just finished his cardiothoracic surgery. These two are two different surgeons. But if you take a randomized trial, both are randomized at the same level. So when we start going into more complex devices, be it Impella, be it anything, a learning curve is very important.
Yeah.
You know, another way to address...
Factor in the learning curve in these randomized controlled trials, because whether you like it or not, below nil, it's not going to be putting this Impella. A Joe Blow in some peripheral hospitals will be putting this Impella.
Well, isn't that the same as TAVR? Isn't that the same as bypass? Isn't
Yes.
that the same as anything else? I mean, if you do something invasive, skill matters. There's no question about that.
So we need to factor
right?
that in, otherwise we'll keep having corrupted data like this and making...
So can
Oh, let me just make a quickie comment related to this. Another way to deal with it, because you can't do a randomized trial, let's say, if you don't have enough patients, is to create a performance standard. And if you can create a performance standard saying that, assume you had the right training and you're doing it correctly, then we could then put the economic variables of correct performance, and that becomes the standard of which we want to achieve. Not a ridiculous performance standard. We had to deal with this with the total artificial heart, because you couldn't recommend, and we did this with the FDA, you could not randomize to device or death. No one would enter the trial. So you basically had to create a performance standard, and I think that that's a way forward which can short-circuit and speed things up, plus it accomplishes what we want to achieve, which is economic variables that we deem important, not being told by an administrator. And it's another strategy that we should start to think about.
But I think all this leads to the discussion that we've done this in VADs and transplants where we have an accountability. So we look at the processes and we're very conscientious about each center having their own solutions. For shock, we're in a stage where we're building programs across the country. Should we be talking about performance standard and cost effectiveness as a quality metric so the hospitals are forced to create solutions? If we don't have that metric, I don't think we'll ever achieve that, because we're shifting risks, right? We're going from higher risk, we don't want to do high-risk transplants, we'll do VADs, we don't want to do high-risk VADs, we'll do Impella, see if we can bridge them. So that cost accountability might need to be come from the leadership level, saying all centers need to meet that performance.
Good point.
Thank you. Thank you, Dr. Cox. I appreciate it. Perfect. So